Thanks, Hector. Don't you just hate biographies? I never recognise myself when someone speaks it out. Folks, it's a delight to be with you today, and I'm going to tell you a little bit about our approach in Scotland in terms of how we try and reconcile these different features just now. Before I do that, what I want to do is I want to start with a little story, if I may. I'm a GP by background and spent 15 years as a family physician in a relatively deprived area of Scotland. And I have to tell you, it's one of the most glorious parts of my career, the time that I spent there, getting to know that local population. I want to tell you about a patient by the name of Margaret. Margaret was in her early 90s, and she used to come and see me roughly every month. She used to walk along to the end of a road and get the bus down to the surgery, where she would sit in the waiting room and she would chat to other people in the waiting room, and then she would come in and see me. And she'd talk to me about her knees. You see, Margaret had painful knees. She had osteoarthritis. And she used to sit there, and we would talk through her medication, how the paracetamol was working for her. I would lay my hands on her knee, and I would examine her knee, and we would go through what almost became a ritual every time that she visited. And occasionally I would put my hand on her pulse, or I would take her blood pressure, and we would have a chat about some other things. And we'd agree that the paracetamol was perhaps still the best course of action for her, and she would go away quite happy until I saw her again in a month's time. Margaret was lonely, and that visit every month served a really useful purpose for her. I came in one Monday morning and came into a discharge slip from the local hospital that told me Margaret had been admitted with chest pain. And the diagnosis on the discharge slip was chest pain, query, ischemic heart disease. And underneath that diagnosis was a list of her new medications. So the paracetamol had been replaced. She was now on cocodamol, a compound analgesic. And alongside that, she was on a statin, she was on antiplatelet therapy, she was on antihypertensives, she was on a nitrate, and perhaps best of all, she was also started on fluoxetine for the low mood that she felt she had in hospital. It was little wonder that Margaret had low mood. And when I went to see her and we discussed her medication, it was an incredibly challenging and difficult conversation as we spoke through, well, maybe some of these medications were not the best for her at her stage of life. You could argue that each one of those medications had a place. The guidelines said so. But what had failed to happen was they'd failed to recognise Margaret's unique context. Margaret's no different from an awful lot of other people in Scotland. This is a slide which shows our increasing population in Scotland. You'll see the striking rise in older people that between 2010 and 2035. 82% rise in over 75s is anticipated during that time. I guess we're not any different from other countries when we see that. And we have to remember that behind this, this is a success of modern healthcare. This is something we should celebrate. People are living older. But maybe we need to change the way that we think about delivering that care, mindful of that new context. Because like many other countries, multimorbidity is very, very common in Scotland. And this is a wonderful trial which was first published back in 2012 by Stuart Mercer and his team, which showed the prevalence of multimorbidity in Scotland. The really important thing about these figures was not just what you see on this screen, but the fact that actually there's more people with multimorbidity under the age of 65 in Scotland than over the age of 65. And that in those communities that suffer more deprivation, those multimorbidities occur on average 10 to 15 years younger. So we can't keep on going the same way that we've always been doing things. And this is a trial just published a couple of weeks ago by Bruce Guthrie from Dundee, which actually looks at the place of modern guidelines and their relevance to people who experience multimorbidity. So what's our response? In Scotland, our response started as a conversation around 6 questions. There were 6 linked questions. The CMO, Catherine Calderwood, and I were fairly new in post at that point in time. We wanted to start a conversation with the profession. We wanted to re-engage with the profession at that stage. And we thought that this would be a good conversation to have. And let me tell you, we were blown away by the response that we had. I think one of the successes of the conversation was the fact that actually it reflected a conversation that was already taking place in hospitals, in GP surgeries, in theatres, right across the country. So what is realistic medicine? Well, at the heart of realistic medicine, what we started to describe was perhaps a philosophy that people mattered, that we needed to better understand people and what their preferences were, that we needed to achieve better relationships, both between the people we provide care to and healthcare professionals, but also between healthcare professionals, that we needed to address the waste and harm that was happening within our system because of unwarranted variation, that we needed to be better at managing risk and innovating, and that we needed to look out for each other an awful lot better than perhaps we were doing already. And it's been one of the most fascinating periods of my career as we've developed what was initially a philosophy into something which has become really the way that we do things in Scotland. So what do we need to do? First of all, we need to listen to our patients, find out what matters to them, help them make an informed choice, listen properly to understand. We not only need to address under-treatment, but we also need to address the over-treatment that goes on within our practice as well, and challenge variation that we would deem to be unwarranted. First of all, we need to understand what's behind variation. And there's many ways that we can do that by better use of data. And we need to get better at offering not just high-quality care, but higher value care. For me, this is really, really important, because we can deliver low-value care, care that perhaps doesn't have a significant beneficial impact for patients really, really well, and that would be high quality. But it's not high value. And what it does, it confiscates resource that we would use in the system to better effect within treatments that perhaps don't have as much impact as we would want to see. This is our vision, is that by 2025 we'll demonstrate our professionalism through the approaches, the behaviours and the attitudes that we would associate with realistic medicine. To do that, we know we need to get better at communication, about listening, about understanding, but we also need to know better from a patient's perspective what it is that they want. Our citizens panels consist of just over 1,000 people, and we've worked closely with them, surveying them to try to understand better what they want from the relationship with their clinicians. We know that broadly 9 out of 10 of them want to be part of that decision-making process, feel that they're able to participate in something, but actually there's something that holds them back. There's obstacles that get in the way. One of the things we've come to understand is that one of the biggest obstacles to that is actually the prevailing health literacy levels which exist across our society. And again, Scotland's no different from other Western societies. If we make the assumption that the conversations that we're having with people will lead to understanding about the treatments, then there's every chance that we will fail to get our message across successfully. And we've produced a health literacy action plan in Scotland called Making It Easier to try to address some of those known health literacy problems within the system. Fascinating fact that I came across during the production of this was that in the UK, 43% of parents are unable to calculate the dose of paracetamol for their children from the instructions on the side of a paracetamol bottle. 43%. If we make assumptions that the conversations that we have with people are going to be understood, then we stand the chance that we'll fail in getting our messages across. And don't get me wrong, I'm a real believer in science and evidence, but I want to strip it back to the beginnings of evidence-based medicine. and to make sure that we rebalance what I think has become out of balance, so that when we think about evidence-based medicine, we not only think about the science and the evidence, but we use that together with our clinical judgment and also with properly understanding what the values and the preferences of the people that we provide care to are as well. And Professor Kinsella is sitting in the front row, and he and I have had many, many conversations around about this. And our minds, I think, are of the same. One of the things I wanted to highlight to you today was just an example of some of the things, the steps that we're taking to try and improve things. 2012, we produced our first guidance in Scotland to tackle polypharmacy. Just before we started today, I tweeted a link to a new app that we've produced, and you'll be able to see that there. And this is designed, this is the latest iteration, the third iteration of our guidance, 7-step process, holistic, person-centred process, fully involving people and their carers in terms of properly structured conversations around about their medications. I think it contains some fascinating tools. It's using evidence in a slightly different way, much greater reliance on number needed to treat, on cumulative toxicity of different drugs when used together. And what we can already start to see is that the 120,000 polypharmacy reviews that we're conducting every year in Scotland are starting to have an impact on the volume of prescribing. Before that, our number of items in Scotland for prescriptions were increasing at a rate of probably about 3% each year. And since the introduction of this guidance, what we're starting to see is that rate of increase is slowing down. And in fact, if you look at the modelling for this, there's probably been about 1.7 million less prescriptions than we would have expected since the introduction of that evidence. Just an example of where that kind of proper conversation with people can actually lead to different approaches. This is the desktop version of the guidance that people can use. It shows some of the tools that we have in it. There's, as I say, number needed to treat charts, a cumulative toxicity tool, and also sick day rules, so that people who have perhaps are on ACE inhibitors or insulin or whatever know what to do when they become ill with the medication. And later on this year, what we'll also introduce is an app which is patient-based, so that they can use this as well. The other thing we're working on just now is the review of consent within Scotland. In the UK, there was what I can think is a landmark judgment through the Supreme Court called the Montgomery ruling, which examined the way that what we mean by proper informed consent. It was based on a case in Scotland where the obstetric care given to a mother and her baby was thought to be inadequate. The important thing about this ruling is it changed the dimension of what we mean by informed consent. And so what we have done now is we've examined the guidance with the General Medical Council and the Academy of Medical Royal Colleges, so that we can produce new guidance for our clinicians around about what we mean by proper informed consent. And a crucial component of the Montgomery ruling is that now they must be able to demonstrate that they have discussed the options for treatment with the people who they are consenting, and that those options could reasonably be understood by the person who is taking part in that conversation as well. A complete different approach to what we meant by consent previously. The other thing that we're doing is we're introducing the 5 questions promoted by Choosing Wisely across the country. So we've got various tools that both within kind of clinical environments that encourage patients to be regularly asking these clinicians asking patients to ask clinicians whenever they attend any clinics or GP surgeries. And there's a national evaluation looking to see what impact that has on choices. We also recognise that some clinicians will need supported to approach what is perhaps a slightly different way of practice. So we're looking at how we embed the principles of realistic medicine right through lifelong learning, starting at the undergraduate level, right through specialty training, and also through our continuous professional development as well. And one of the most common challenges that I hear from clinicians, but if you practice this way, will it not expose you more to litigation, to complaints? Actually, the evidence suggests otherwise. The evidence suggests that if we practice in this way, if we fully involve people in those conversations at a level that they can understand and fully participate in, then it's much less likely to lead to complaints. And we've engaged very closely with the Scottish Public Services Ombudsman, but also with medical legal experts across Scotland to make sure that the positions that we're taking in relation to this have some basis and evidence behind them as well. So let me summarise about where I think this takes us in terms of our approach in Scotland. I think strong recommendations are very powerful. I think guidelines have helped us improve the quality of care tremendously since we have adopted them at scale. But if we're going to embrace a new and equal relationship with patients, then we must also view eliciting patient preferences as an essential part of the consultation. And I think if we can do this, fully embracing the context of health literacy that person brings to the consultation as well, then the conversations we have to inform better choices, better adherence to treatment plans, better outcomes, less treatment regret, and we'll deliver a much more realistic form of medicine in Scotland in the future. So thank you.